So let's move on to the next talk. This is from Dr. Paul Edison, and he's going to talk about neurological complications of COVID. Paul is a clinical senior lecturer in neuroscience at the Department of Brain Science at Imperial College London. He's editor-in-chief of journal Brain Connectivity, also consultant physician at Hammersmith Hospital, and recently published a nice paper in the BMJ on July 2021 on long COVID mechanisms. So, Paul, thank you very much.
Thank you very much, Maria. Thank you very much for that introduction and invitation to this talk. As many have mentioned, we just produced this paper, but more importantly, just to say this coronavirus can have influence on almost any systems of the body, as Janet alluded to. But what I'm going to focus is particularly on the brain and probably one or two slides just to finish off with in the lung as well as the cardiovascular system. So what happens with COVID in brain? As we all know, that the main thing which we see once the COVID infects or the coronavirus infects a person's body is this immense cytokine storm. And that can cause raised interleukins, inflammation, and tumor necrosis, and various other pro-inflammatory factors. So once these inflammatory factors are there, these things can influence the brain. Added on to that inflammation, there is this hypercoagulable stage where you could see there is increased coagulation and probably leading to stroke. The other reason is there is increased hypoxia and there is stress, and added on to the cytokine release. This all can cause a significant damage to the brain. So what are the things happening in brain? One of the commonest symptoms most of the people were saying is the loss of smell. How does that happen? It's probably there is this coronavirus enters to the epithelial cell and it damages the epithelial function. So there is some debate about how much is it attributed to the epithelial function, as well as how much is attributes to the olfactory nerve and the structures behind that. And the jury is still out, but I would say probably both of them may be contributing to that, even though the epithelial function or epithelial dysfunction comes first. Now, if you get there is hypercoagulable stage, you can very easily get small and large vessel occlusion in the brain that can lead to stroke, and they can also lead to microvascular complications. And the high levels of cytokines that can damage the blood-brain barrier integrity. So once the blood-brain barrier is damaged, these inflammatory cytokines can enter the brain, and that can also damage the neurons, and there could be glial activation. I'll come back to that a bit later. And there could be damage to the arteries and meninges, and this all can result on the stroke as well as meningeal inflammation. And as Janet mentioned, there could be autoantibodies, and that may lead to damage of the cranial nerve. So there are multiple pathologies happening in people with COVID. Now, the real question is, can COVID-19 boost the epidemic of neurodegenerative disease? I mean, we know there has been a significant debate about the people getting depressed. Is it because of the lockdown or is it because of COVID? And the reality is probably due to both. But what about the hardcore symptoms of neurodegenerative disorders and along with the stroke? So we know the ACE2 receptors are expressed in the neurons and neuroglia. And when the virus attacks, so virus can get into the brain either through the olfactory system, or it can go through the the blood-brain barrier leakage, and the virus can get in. Once the blood-brain barrier is leaking, then the systemic inflammatory markers can get into the brain, and these can actually activate the glia and cause a neuronal damage. So there are multiple pathways, even with a single infection, even in the nervous system. So again, this is just showing the neurotropism of SARS-CoV virus, and this is showing that there is an inflammatory cascade happening in the bloodstream, and that is can cause the blood-brain barrier leakage here. And this blood-brain barrier leakage causes not only sometimes the entry of the virus, but it can cause these pro-inflammatory cytokine intrusion into the brain tissue, where it can cause the reactive astroglia, and there is increase in the pro-inflammatory microglial activation, and because of the overwhelming presence of the pro-inflammatory cytokines. And these are particularly important in the persistent long-term complications of COVID, and we are yet to know what exactly will be the long-term damage in people with CNS involvement. So what happens in nervous system when there is inflammation? So the normal function of microglia in the brain is to protect the brain. And we know that these microglia are present in the brain right from the birth. When there is a small insult, the anti-inflammatory or the protective phenotype of the microglia gets activated. The idea is that it tries to clear whatever is the inflammation or the trigger which causes the activation of the microglia, and then it protects the brain. But if there is excess inflammation and where microglia can't cope with, or the anti-inflammatory microglia in the brain cannot cope with, what happens is they change into pro-inflammatory phenotype, even though it is not that very simple and straightforward, nor linear. But in reality, what happens is these pro-inflammatory cytokine microglia produces cytokines. Added on to the cytokines introduced through the blood-brain barrier leakage, that can cause neuronal damage, and that neuronal damage can perpetuate. And once the neuronal damage is triggered, as it happens in Alzheimer's disease, that itself can cause a vicious cycle of microglial activation and neuronal damage, and this cycle can perpetuate and cause progressive neuronal or neurodegeneration. Added on to that, there is this, if we still yet to figure out about what happens to the autoimmunity. We know what happens if there is ischemia, thrombosis, and stroke. We'll come back to that. However, these things can cause lasting damage, leading to some of the neurological complications. So again, what is the mechanism in the nervous system? There is circulating virus, there is cytokines, and the so-called DAMPs, which is damage-associated molecular protein and a pathogen-associated molecular protein. And these things act on the endothelial cell, and this leads to inflammation. Inflammation of the endothelial cells in the blood-brain barrier can lead to opening of the blood-brain barrier, and once that is open, that results in the damage of the neuron and lead to cytokine sickness and encephalopathy and various other neurological manifestations of COVID-19. So now the question is actually these long COVID symptoms or the neurological complications, they actually present the viral infection, and do we can use any antivirals or anything at that point, or whether it would it is much more than just a involvement of the virus. Again, the virus, what happens is in most of the patients, there is a primary viremia. It goes into the brain through the different mechanisms, which I already mentioned. It can also go to the lymphatic system. And if the patient's immune response is satisfactory, then it could have resolved. Or if the immune, depending on the host susceptibility, if in some patients it may have isolated meningeal syndrome, some irritation of the meninges or some confusion. Some can have frank encephalitis. And if they're immunocompromised or they're severely affected, that can lead on to meningoencephalitis. So it really, then all these symptoms then lead on to the prolonged, persistent symptoms depending on the involvement. That also begs the question how we are going to predict which people are going to have these persistent symptoms. This is just to go through briefly what are the symptoms. People can get a headache, dizziness, ischemic stroke, cerebral hemorrhage, and they can have disseminated encephalomyelitis, optic neuritis. Clearly, there's a decreased level of consciousness and encephalopathy in the acute phase, but in certain people, that can persist. And you might have heard several people saying they were in the ITU for a very long time. And some clearly due to their lung problem, but there's also issues with the respiratory centers and the breathing patterns and various things. And they can have encephalitis and seizures and so on and so on. So this, the whole host of things are happening in patients with COVID, but more importantly, we are still unable to predict which of these patients are going to have these symptoms, and more importantly, how to treat these symptoms. So this is just to illustrate that there has been different studies. There's quite a lot come up in this year as well as last year. There are some of them are very vague: poor sleep quality, neuropsychological features, post-traumatic stress disorder. Again, the cognitive deficit, depending on the population they have studied, varies from 10% to 50%. And again, there is also the selection bias, which patients are being involved in the study. But the summary is that there are quite a lot of symptoms being, these patients are having quite a lot of symptoms which are persistent. Now, just to illustrate what we see, so this just to show a 58-year-old gentleman who had severe COVID and who was treated with the dexamethasone. What you can see in the MRI scan is there's a significant confluent hyperintensity. And so these patients didn't have significant focal deficit, but they had significant changes in the MRI, and this will subsequently lead on to some of long-term consequence. Again, this is another patient where they had a significant cytokine release, and it has induced edema in different parts of the brain, which you can see. There is bilateral thalamus involvement, as well as the brainstem and various other structures. And there is also some amount of hemorrhage. Again, this is another patient who had encephalitis, and what shows is a high signal intensity in the splenium. So what I'm trying to highlight is that the manifestation in different patients is clearly different. And more importantly, we are still unable to predict which patients are going to have this. And moving down the line, we will have some difficulty in figuring out actually how we differentiate these things from the pre-existing vascular disease, or indeed these are new complications from COVID. This is another 65-year-old patient with extensive subcortical ischemic lesion. Again, we presume that this patient didn't have these subcortical lesions before he had the COVID. And this, as you can clearly see, the several sites have got a significant involvement in the brain. And we know that COVID is associated with a significant vascular or thrombosis, both in the pulmonary artery, as well as that thrombotic tendencies throughout the whole body, and particularly manifested as a stroke in several of the patients. And very early on in our treatment protocol, actually, any patient who came to the hospital, we initiated anticoagulation. Again, some patients can present with these little black dots, which we are seeing is the microhemorrhages. This is a 27-year-old male patient with an acute leukemia. Obviously, he has got some underlying disease. What we are seeing is there's several microbleeds in these patients. So now we have got coming to evaluating these patients, which we, apart from the MRI scan, which is classically and widely available, we have different tools at our disposition now. And my main focus has been neuroimaging with very novel PET markers. So what I'm showing this is the amyloid imaging. What we have demonstrated in Alzheimer's disease 20 years ago, pretty much, is that in patients who have got Alzheimer's disease, there is significant amount of amyloid compared to healthy control, which is on the left-hand side. And we are still not sure whether these COVID and other viral infections can induce amyloid production. But there is chances that there is accelerated neurodegeneration. This is one of the tools at disposition, and we will be trying to look at what happens in these patients. The other thing is FDG PET, which looks at the cerebral glucose metabolism. So this is a healthy control subject on the left-hand side, and this is the Alzheimer's patient. What we see is there is reduction in glucose metabolism. And on the right-hand side is just as comparing that with the amyloid PET. Now, other tracer which we use is microglial tracer. Again, these are patients which we call the mild cognitive impairment patients, which are showing significant amount of inflammation in the brain. And this is compared to the control subjects. And we all know there is significant amount of tau formation in patients with Alzheimer's disease. We believe this can happen in patients with a coronavirus infection simply because of the significant amount of neuroinflammation and neuronal damage. And we can now actually image these patients. Again, we haven't got data on COVID patients, but this is just to illustrate in Alzheimer's patients, we can image people with a significant amount of tau deposition. So it's just to illustrate, there are different tools which we could use to evaluate these patients. Again, MRI, it's a well-established and widely available tool where you can see in patients with a neurodegenerative disease, particularly Alzheimer's disease, we see significant amount of atrophy. People who are subtle memory problem, called the mild cognitive impairment, we would also see significant amount of atrophy, even though these patients are not demented. So there are quite a lot of tools at our disposal to evaluate the brain function. And this is just to overall picture of different things which we can evaluate. I must admit some of these PET scans are expensive. However, these tools are widely, or at least reasonably available, both in UK and pretty much widely in US and other countries. So what did the COVID-19 patients show with the FDG PET? This is some studies done. Pretty much, these are the patients who had new onset cognitive disturbance. They had a normal MRI scans, and they did not have any features of encephalitis or significant CSF abnormality. What it showed is that in different patients, there is a reduction in glucose metabolism. So this is not at the time of acute infection, but later on, so there is a reduction in glucose metabolism. These reduction in glucose metabolism varied depending on different patients. So we cannot anticipate that all the patients are going to behave exactly in the same way. This is another study which where they followed up patients 1 month later and 6 months after COVID-19. What it shows is 1 month later, there is still significant reduction in glucose metabolism, and that persisted even after 6 months after the infection. So now coming to, apart from the neurological symptom, there is several neuromuscular symptoms. I know Janet has greatly covered the myopathy and muscular systems. I'm not going into that. This is just to highlight the neuromuscular junction involvement is another reason which where some of these problems are happening. We're yet to see enough evidence or data to support that. I thought with the brain, I have to mention about the mental health side effects. I can see a significant proportion of patients that have anxiety, mood, and psychiatric disorders in about 23%. So this is a data from 230,000 patients. Around 23% of these people have got either some sort of mood disorder, psychiatric symptoms, or neurological symptoms. And they also some, whether it is a combination of being locked in or housebound at home, or there is some increase in substance abuse, and there's also the insomnia has been reported. But in general, these figures are consistent across the studies, pretty much highlighting the significant proportion of the patients are having symptoms from the mental health. I know Janet touched on the data from August from the Office of National Statistics. There is some released on 2nd of September, again highlighting from the 970,000 people living in UK, according to them, 1.15% of the population were experiencing long COVID symptoms. They said more than 4 weeks after COVID infection. Now, one of the things is 817,000 of the patients had either had the infection or they suspected that they had. And these figures probably are not hugely accurate because they are self-reported symptoms. There is a inaccuracy about whether the infection is there. But however, what it says is that a significant proportion of the patients have got long-term effects. And one of the things which is interesting is to see is that 643,000 people mentioned that they were adversely affected, or their symptoms adversely affected their day-to-day activities. Again, fatigue is one of the commonest symptoms, followed by shortness of breath, and then comes the muscle ache and difficulty in concentration. That's about 31%. This is just for the completion's sake. I mean, there are again the different studies have reported varying proportion of patients with problems with shortness of breath. And again, different proportion of patients have presented with chest pain, chest tightness, cardiac involvement, and significant proportion of patients had high myocardial enzymes during acute admission. And there's a lot of patients had pericarditis and chest pain, palpitation, and dysautonomia is one another feature which these patients present with. Again, the mechanisms by which how the persistent effect on the lung is because of the pulmonary fibrosis. More importantly, whether there is a vicious cycle of inflammation going on in the lung. As you know, several of these patients report CT findings even after a year. Then if you're coming to cardiovascular symptoms, again, there is the acute injury, there's myocarditis. Then the question comes, these arrhythmia and thromboembolic events and the coronary heart disease that all can lead to long-term complications in these patients. So with that, I will stop, and I'm happy to take any questions. And thank you.
Thank you very much for that talk. Highlights the complexity of everything that's going on. And there are so many different symptoms, so many different manifestations. It's going to be a challenge to try to understand, but also to try to stratify patients. So one of the commonest things that patients come back with in terms of symptoms, they say brain fog, which may mean different things to different people, inability to concentrate, etc., forgetfulness, etc. So has anybody looked at systematically what different people mean by a brain fog?
Well, I think there's, it's a very difficult one. I think what most of the people, including ourselves, are trying to do is to evaluate their symptoms. One of the things which is slightly easier to evaluate, at least, is cognitive function. So there are several studies across the globe trying to do different memory tests. The complexity of those tests, if somebody comes who is young and say, oh, I get a bit of difficulty in concentration or this brain fog, and trying to elucidate that, it needs a pretty in-depth evaluation of the cognitive function. So some of those studies are happening, but I don't think we will be able to precisely say, what exactly this brain fog means. It is a combination of lack of concentration to some involvement of the nervous system, whether it is due to the cytokines, whether it is acute inflammatory response, leading to some recoverable or damage in the people who recovers. Obviously, there is a proportion of the patients, and it has been reported up to 50% of the people can actually have cognitive impairment following that. Now, because so many of the studies haven't got the cognitive function prior to the infection, it is going to be challenging, and the money will be for the cohorts who have been already following these patients for the cognitive function, so they have got the cognitive battery test of the results done on those patients in large numbers. And if they had we know that a smaller proportion of those patients who already had the cognitive function before had the COVID, and trying to follow them up after the COVID infection to see how they are behaving. Clearly, we are able to see whether there is any longitudinal progression of the cognitive impairment in these patients, which is slightly easier because we have at least 2 or 3 months after the infection, we get a reading. Yeah, so there's quite a lot of work is going on in that sphere.
Okay, Great, thank you. Mark, you've got a question. Mark Lazarus.
Thank you. So yeah, both really lovely talks and really informative. My question is sort of, there's two questions which are sort of partially related to one another, to both yourself and Professor Lord, if she's also still on the in the talk. The question's about interferon alpha, and I sort of come to this with a bit of a disclaimer that I'm representing AstraZeneca, and we have a drug that blocks interferon alpha activity. And one of the things that surprised me in both talks is that you haven't mentioned interferon alpha, and this also goes through to you know, a lot of the reviews that I've read where there doesn't seem to have been much interest in interferon alpha. Mostly it seems to be around IL-6, IL-1, and TNF alpha, as I just noticed as well. And yet interferon alpha is the key cytokine, the key antiviral cytokine. So I just wanted to gauge from you whether this has been looked at, whether interferon alpha has been explored, what its possible role is or isn't. And on that point, I'm also just curious about hydroxychloroquine, because obviously there was this great Trumpian excitement about hydroxychloroquine, which was always a bit, you know, which was always very overblown right from the beginning. But hydroxychloroquine, has an anti-interferon alpha effect, and so I thought there was a possibility that it might have some benefit, if not in acute COVID, then possibly in post-COVID, in long COVID. But also particularly with some of this brain fog issues, we sometimes use hydroxychloroquine in the rheumatology clinics for lupus patients. Some of them report improvements in sleep, improvements in brain fog, etc. And I sort of wondered whether there was a possibility of re-exploring hydroxychloroquine and maybe sort of looking back at some of these patients who had it, and whether that led to a reduction in long COVID for those that took it during their acute admission or pre-acute admission. So just, sorry, it's a lot there for you to go, but just wondered what your thoughts of those two issues might be.
So I think it's a very, very interesting question and very pertinent. I must admit, a closely related compound, which we put it to NIHR for funding. And unfortunately, they said, well, it's too much of a pie in the sky. However, I fully agree. I mean, interferon alpha, as well as other cytokines, do play a significant role, both in neurodegenerative diseases. And particularly from my point of view, I think once the cascade of inflammation is triggered, there are only a few things which we could influence. So in that respect, I would be very keen to actually talk to you after this to see whether we can look at that. Just to clarify what I have been doing, you probably wouldn't know. We are looking at the brain inflammation. That is my focus, with the various PET markers and how we can dampen the inflammation. Now that even though aducanumab has been sort of licensed for Alzheimer's disease, people were of the belief that inflammation plays a significant role in neurodegenerative disease. And I agree that with the COVID, it's very clear that there is an inflammatory trigger, and that is the one which is causing the progressive neurodegenerative damage in those patients. And as I have demonstrated, this vicious cycle is likely to happen, and anything to stop that cycle is what is necessary. And our main criticism from the NIHR application was, we have to demonstrate, we need some pilot data, et cetera, et cetera. I mean, it's a chicken and egg situation. We need money to generate the pilot data. However, but I strongly believe these things needs to be tested. It's not only, interferon alpha, anti-IL-6 and various things which we may have significant effect. That may also boil down to how we identify the Munia's point about the stratifying patients. There is a way of identifying patients who have got inflammation. We can't treat everybody. to see, we may have to go through the cascade of tests, however, identifying the right patient for the right treatment. And so I fully agree with you that there is a role for that. Now, regarding chloroquine, I must admit my ignorance about the mechanism of action. So perhaps I'll leave that to Janet to comment on that.
So I'm so sorry to cut across. I'm just conscious of time. We are supposed to be having a break, and maybe some of those conversations could go ahead in the breakout groups later on. So can I suggest that we break for a short while? People may want to get a cup of coffee or something like that. And we were due to break till 12:15, but maybe let's come back at 12:20. So that gives you 11 minutes break to make a cup of tea or coffee, and then come back for Kieran Collinson's talk, if that's okay. And then Charlotte Summers' talk after that, if that's okay.
Thank you.
Great. Thank you very much for your talk, Paul.
Thank you. Bye-bye.